This seems overly formal.
Yeah, I know.
By the way,
It's like weird. We're like sitting up here. So I actually didn't present. My name is Matt Burton. I'm a physician informatician. Did a lot of work at Mayo. I now do a lot of work in standards and that are basically trying to solve different aspects of. So I work with upstream evidence, synthesis, all the way to provider organizations trying to implement, and not everybody in between, professional societies and vendors and accreditation groups and all kinds of.
It was like an interrogation. I believe for vaccines we should follow the science. Too soon? Sorry. Okay.
I'll give you like a simple one. I think I've described this to you before, but a simple one. So honestly, like some of these state things, right? Like first of all, we just used like a very simple kind of logic called state machines that have been around before computers, right? Like they were used to describe like chemical reactions long before computers. They've been around for like 120 years to describe how like chemical reactions occur. Like for a state, you have the intermediate kind of thing. And so like what I've done in the past is just like a lot of simple things that are like the things that physicians learn in medical school and like just become part of the conversation, but don't make their way into the medical record. And if they do, that's not as discrete data. So things like hemodynamic status consisting of perfusion status and volume status, right? Like those are things that get talked about, but where do you see it in a medical record, right? So those are like the simple kinds of things that we look at, or we would look at, things like post-op bleed, right? Like if they haven't had surgery, they can't have a post-op bleed, right? So they're in a state where they're not at risk, right? And then we would have like an elevated risk, we'd have at risk because they had a procedure, elevated risk, and we might have some other algorithms that would feed into that. But honestly, like a lot of the patient state kind of information can be really, really simplified, but it maps to something that is physiological, pathophysiological, or even clinical, right? But in I think some of what you were talking about, like actually gets more into really like phenotyping and subphenotyping, right? Where you can get down and you can look across physiological processes because there's systems biology that's going on, right, that we all know about that are going on. And that's, I think you mentioned being a biologist, several mentioned I'm also a biologist, and that's what we are, right? We're chemical reactions at one level, like we're just atoms at one level, but we're also very complex adaptive systems. And it's like, how do you find the right levels to track that? And you are using some different data in some cases to start tracking that. But part of my point is there can be very simple things to do that, right? But there can also be very, more sophisticated things that are looking at how this complex biological system is evolving over time.
Yeah, and I would add, I was a little bit, admittedly, mixing like apples and oranges, right? You can do this across lots of levels, right? The original smart monitors were just, the heart rate went up and the blood pressure went down. We're going to turn from green to red and flash a warning, right? Very useful, not very sophisticated. With very simple physiology that we monitor all the time, just an EKG and some vitals and some like contextual knowledge, you can get a lot of state identification, which can not only help you get to the bedside. There was that example of that sepsis score for the neonates. That's just heart rate variability from the EKG waveform and a little bit of blood pressure and, 22% mortality reduction. Again, not giving them a CPG, not telling them what antibiotics or what to do, just getting the people that are smart to the bedside to do what they already know how to do. That's a huge example. A lot of what I showed at the end with the T6 was just, okay, here's a patient. Now you've told me that they have a gunshot wound here and they've got a burn to the leg and their vital signs are this. Now the logic says that this CPG applies, right? And now when you say, okay, I did this, that, and the other thing, and the physiology got better or got worse, another CPG applies or another warning. And it's just like really smart logic that mimics what we do clinically, which is frankly better than just being like, I I've got this patient, I think I probably need to look at these 5 CPGs, so I need to go to a resource of where to get them, but I have to like think of what I need to go get, whether it's easy to go get it on an app or hard to go get by Googling or whatever. It's still, you have to figure out what you're going to get. And then you can get really, what I tried to show is you can get really sophisticated into biology, and I think we can dimensionally reduce that, where it's just a little blood on a chip to really determine where your patient is in that biologic state space. The implementation is really interesting. Like, on the one hand, as a scientist, I want to know, oh, those patients have some really cool mitochondrial dysfunction at, the electron transport chain. we're going to spend a decade trying to make a therapeutic for it. As a clinician at 3 in the morning, I just want to know they're screwed up and that I got to go to the bedside and do something about it, And so we can talk out of both sides of our mouth, use the I just want a warning on the one hand, while also really getting into like understanding the biology. And then maybe 5 years from now, we'll have 5 syringes in a medic's backpack. 1 drop of blood. I mean, this is really tractable, and I think we really will get there. 1 drop of blood on the chip, and they get syringe number 3 because we know that's the therapeutic that they need while they get evacuated. Or in a civilian center, you could be even way more sophisticated because you've got lots more interventions to play with. I think that's the future. But for now, very simple physiology will let us like target the CPGs and get us to the bedside to do the right thing.
And nurse writes it on a piece of paper because they can't keep up. And when you're the CAT scanner or the dust has settled, they go, oh yeah, by the way, the blood pressure was, 60 over 40 20 minutes ago. Same with T6. We tried it with the nurses, failed. I thought, maybe the nurses are a generation removed. I gave it to the medical students. I traded clinical knowledge for Instagram knowledge. Medical student couldn't keep up either. We ended up giving T6 back. So do you think today we should be better off thinking about how to implement clinical practice guidelines and make them uniform and operational and all that outside of the trauma bay, like when we're rounding or in the ICU, where time is not of the essence? And maybe we can attack the trauma bay phase 2 because I don't think we have the time to implement information and then have a pop-up come up and go, oh, by the way, you should consider ED thoracotomy right now.
Yeah, again, I think it's a matter of how sophisticated. We talked about this in the last room also. What's the difference between you being an expert with a ton of domain knowledge and experience versus somebody who's never taken care of a trauma patient at a non-designated trauma center when it shows up on their doorstep, right? I think we can walk and chew gum at the same time, and I think there's something for everyone, right? On the one hand, you may want some augmented guidance that your patient's a little bit different than you think they might be, or a little bit odd, and it's going to really alert you, or you're just cognitively burdened because you got lots of patients and lots of things going on and you need to focus. That's useful in the heat of battle, but it's also really useful when we're not paying as much attention and trying to make sure they got their DVT prophylaxis, day 7 when we're kind of half listening on rounds, right? I mean, let's be honest. I think those are both useful. Sometimes it's something I've never done before, right? Or like, I'm really tired or really burdened. Yeah, or it's my intern who's never done it before. Yeah, I don't want them to think. I want you to just follow the damn steps, right? Like, and so it's really, really useful. And that's also really useful for somebody who doesn't take care of trauma patients. So I think we have the knowledge, we have the guidelines. Now the question is, how do we get the right guideline to the right person at the right time? I think that's so incredibly important, because you get something that's too complex to somebody who doesn't have experience, they're going to be like, this is too complex, and they'll blow it off. You get something that's too simple to people who are already experts, like, I know what to do. I don't need to do this. And I think the answer is like, God, I would, all those sepsis alerts come on Cerner or Epic, right? That I just reflexively just cancel without even looking at them. How do we get past that? I think is the real issue,